ONtheGo podcast.
Cartilage Constellations, discussing the future with ICRS President Daniel Grande from Feinstein Institutes Northwell Health and Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Taka Oshima and this is ONtheGo, the podcast all around orthoregeneration.
Great. So thank you to Daniel for being here on the podcast, the ONtheGo podcast, and we always start with the warm-up question, and that is because it's probably somewhere in the afternoon for you, early afternoon or even morning. But how do you drink your coffee? How often? How much? And where?
Okay, I'll tell you exactly. In the morning, first thing, my wife makes coffee before I even get up. I have a cup or two before I leave the house. On my way to the office, I get a nice Grande, because it's my last name, of course, size Starbucks. And I have that with whole milk. I'll drink that. So I usually have like 2 to 3 cups a day in the morning, never too late in the afternoon, because then I can't get to sleep at night. So that's my routine. In the afternoon, I might have tea.
A tea. Good. And at your working place, do you have a favorite place to just relax a bit and have your coffee in the morning to get away from all the hectic work?
Well, actually, I go to my office and I drink my coffee while I go through my 1,000 emails I get a day. So it's there's really no relaxing, but I enjoy sipping the coffee as I go through my emails, so I can, be in the right frame of mind to answer.
Great. Well, that's a good warm up. But now we know how Daniel Grande drinks his Grande. So we'll get right into it, because this is a warm up towards 2040, like a look ahead into the future of cartilage research, and also yourself, but also autologous chondrocyte transplantation. So we'll start with that. So you're widely recognized as a world leader in cartilage repair, as you pioneered the first cell-based therapy for articular cartilage repair, and that led to the to cartilage transplantation, namely autologous chondrocyte transplantation. And could you tell us a little bit about how this road towards the autologous chondrocyte transplantation went, and how the project started?
Sure. So I was a graduate student at NYU, New York University, and one of the requirements was for us to run a journal club, and I put together a journal club that involved cartilage biology. And at that meeting, one attendee was Lars Peterson, who you probably know, and everyone in the field kind of knows. And he, after the meeting, after the journal club, he came up to me and he said, wouldn't it be great if we could find a way to heal or repair articular cartilage? And I looked at him and I said, well, that's really an interesting concept, because prior to this, of course, no one thought you could actually repair cartilage, because that old axiom of once cartilage is injured, it can never be repaired. And with that, I had already started a thesis project involving bone, but it just wasn't really, I wasn't passionate about it. But Lars and I started working together and with this concept, and we bandied about, we said, why don't we take articular cartilage and expand the chondrocytes in culture and then reimplant them? And we thought about other cell types at the time. Of course, Arnold Kaplan was working on mesenchymal or marrow-derived stromal cells, and we thought about that. But Lars and I were keen on the concept of a chondrocyte because it already had the phenotypic profile that fit into what cartilage makes, i.e. their extracellular matrix components, collagen 2 and aggregate. And so we fleshed out a design. But one of the things that we struggled with was, at the time, now this is let me remind you, this is early 1980s. So 1981, we started working on this. we were looking for some type of scaffold or membrane to hold the transplant cells in situ in place, and there was really nothing that we could find available to us from a surgical perspective. But Lars, being from Scandinavia, Sweden, they have a long history of using periosteum for different things like interpositional arthroplasty and so forth. So he said, since we're going to be operating in this area, we can take a small sample of periosteum and use that as a membrane to cover and hold in place the cells. And so with that, we did the first experiments in rabbits, and much to our chagrin, everything worked out really well as far as the cartilage healed beautifully. We were actually stunned by how well it healed, and the rest, as they say, is history. We went on to then present our work at the Academy and the ORS, and we were met with a lot of incredulous. They didn't believe us that we had done this work. And I remember distinctly Lars being on stage, basically arguing with the audience, saying, no, this is really true. But of course, Lars went on to demonstrate it in the human, in human subjects and patients, and the same same results were obtained, whereby we had beautiful cartilage repair in an otherwise, and it changed really in an otherwise normal joint. But I think what's important is that we demonstrated that something could be done, and as a result of that, of course, it spawned a whole new paradigm shift in the sense that prior to this, the concept of even trying to heal cartilage was non-existent. But now we showed that we could do that, and it was quite compelling and got a lot of press and so forth. So,
well, that's great to hear. And I was just wondering, because probably around the same time, it was also Mats Brittberg who was probably involved, or maybe be from the Sweden perspective on this. What was the relationship and the collaboration between you guys?
Right. Yeah. So basically, Lars was a fellow in New York at the institute that I was at in NYU. And at that time, he wanted me to come to Sweden and do that work. But my wife and I, we just had a baby boy, our first son. So unfortunately, my wife didn't want me to go for a year or so. And so Mats, who was also got involved and basically took my place as the master tissue culture of chondrocytes. So that's how that came about. And there was our institution, the Hospital for Joint Diseases, had a strong Swedish interchange of different folks due to the fact that our surgeon in chief had spent time in Sweden, Viktor Frankl, and so we had a lot of fellows and so forth from Sweden at our institution. So,
okay, then that's also clear. And when you reflect back on this journey towards ACI or ACT, how you want to call it, what were some of the main challenges that you had to overcome, and that you got challenged with, and how did you handle that situation?
Well, one thing right off the bat was this concept of what FDA, the FDA, or Food and Drug Administration, government regulation, how they would view that. And at the time, it actually initial ACI, as originally sponsored by Genzyme, showed that or demonstrated that they could do this if it was autologous tissue, similar to bone marrow transplants, and only autologous tissue was replaced or returned to the patient, that it fell under like that kind of guideline that allowed for a really non-regulatory involvement. But of course, the government stepped in at some point and said, we have to regulate this because it's more than just a marrow transplant. So I think that was one. Navigating the regulatory environment was one, but certainly still, and as you might be aware, or our audience might be aware, the initial use of the periosteum also involved complications that we didn't anticipate, such as hyperplasia of the periosteum due to the fact that once you remove it, it kind of stimulates a bone fracture. So the cambium layer, which we put down facing the graft, which we considered also a source of other chondrocytes that could be helpful, also resulted in a hyper, an elevated surface at that, or a metaplasia or hyperplasia of tissue there. So sometimes people had to go back in there, but and shave that down or remove it. But I think that was a major challenge. To eventually find a membrane that was not reactive, if you will, such as the Geisslich membrane as an example, or other collagen types. So that was definitely a challenge. And then just making sure that the cells were retained in place also was a challenge. So that led to our use of fibrin glue around the seams. And ultimately, when you think about it, it's a two-stage procedure. So other surgeons learning to do an open knee arthrotomy and implanting that, Lars, I have to say, is an incredible surgeon that taught me a lot about surgery while we worked together. And he was capable of doing very fine work with like 9-0 vicryl sutures and really finessed it and very gentle to the joint. Not every surgeon has that capability. So the challenge was to try to make it a one-step procedure and also an arthroscopic procedure. That was the challenge that we were looking to do.
Yeah. And I think that also brings us towards the year of 2024 right now, because now we know a bit of about the challenges that you overcame and together with your team, but looking at this procedure nowadays, what are the main research and from a research and clinical perspective, what are the main unanswered questions in this area, and what do we need to really answer those questions from your perspective?
So I think, certainly there's been a really a bloom or a blossoming of all different technologies that have shown to be effective, at least partly, for cartilage repair. But I think some of the challenges that we still face is, for instance, what I would like to see is something along the lines of so currently as it's practiced, and now we've really moved from ACI or ACT to MACI, where we have matrix assisted, right? So I think the next step that we really should be looking at is the concept of allogenic chondrocytes. So whether those cells are iPS-induced pluripotent stem cells that have been programmed to become chondrocytes, or whether we have the ability to significantly bank chondrocytes that are allogenic and non-immunogenic is really I think the challenge that would make it an off-the-shelf availability to all surgeons and arthroscopically deliverable. So I think that's the future, and what we need to know is which cell type is best. There's still debate. At the ICRS, for instance, we have debates over stem cells versus chondrocytes, which is better. I think those are some of the things we need to really work out, and also integration of whatever implant we put in with the host cartilage is key. In other words, how do we make sure that we have good integration? Because as you know, cartilage does not have a blood supply, so it tends to be rather anti-angiogenic, and lack of integration could be an issue. So I think those are some of the things that we should be looking for.
Yeah. And why does it need to be allogenic in your eyes? I mean, there's lots of discussion about this. I mean, autologous is your own tissue.
Yeah, I mean, I agree. Autologous is best, but it's also very cost ineffective. The business model does not allow, like when you think about companies like Tygenix that went through all the effort to have a good, reliable ACI product that also adhered to GMP and pharmacopoeia guidelines. So in other words, they made sure that the chondrocytes were making the proper ingredients, i.e. Collagen 2, aggrecan, and weren't making collagen type 1 as an example, because chondrocytes, remember, are also highly impacted by their environment. So if you put them in monolayer for culture to expand them, you have to be aware that after a certain period of time, they will become permanently de-differentiated fibroblasts, not chondrocytes. So maintaining that phenotype is important. But I think if we can have an allogenic product that performs similar to an autologous one, certainly to have it available in a clinical setting, so that if a surgeon is doing an arthroscopy and sees a defect that he didn't have, or knows that he's going to deal with a defect, he can easily pull out one of these out of the freezer or 4 degrees, whatever we keep allografts at, and have that available to be put in at the time of surgery. I think that will make it a more readily available product for clinical use, because when you think about ACI currently, it involves 2 procedures: one to harvest the cartilage, and then second to implant it, but a period of 2 weeks to 3 weeks to culture and expand those cells. So if we could have something that's available at point of care, that would be superior.
Yeah, no, I understand. And with regards to the host integration at the cartilage border, what are the current challenges that we are facing? Do we see cysts at those borders, or do we see cartilage degradation at those borders? And how we're going to make sure that the integration at the border will be improved in the future?
Well, yeah. So that's something that we from a preclinical perspective, we can do a lot of work to augment or improve on that issue. But from a surgical, I mean, I think we need to think about maybe things like treating the periphery of a defect with an enzyme treatment that allows for removal locally, or at least at that surface, of proteoglycans or aggrecan, to allow better integration, where cells can freely migrate out from the graft as well as from the host, to allow for better integration. I think that's one method. And certainly having a construct that has good fit, like press fit, that's definitely adhered closely to the to the opposing articular periphery is advised, as well as making sure that it's not too proud, where shear across the surface would help to destabilize and move micro motion that graft. So those are kind of the things we have to pay more attention to.
Yeah, the future thought about the enzymes at the border is intriguing me. Is that something that you're currently working at from a preclinical perspective, or in the lab? Something that you can tell us a little bit more about?
Yeah. So we find that if we pre-treat the periphery with an enzyme cocktail, we get better integration at that interface. So yes, that's been also Arnold Kaplan, the late Arnold Kaplan, also tried that as well, and also had success with that concept. So it's something that we can perform. It's another step, and when we think about translation to the clinic, so arthroscopically, how would you do that? You would need to certainly stop flow of saline, and then allow for a brief intermission with that kind of treatment to allow it to properly set up. Maybe what we can do in the clinic is also have an enzyme pre-treatment of the graft, so that when it goes in, it's also better equipped to allow for outward migration.
And I would think of maybe like dry arthroscopy in that sense, and delivering the enzyme cocktail. Would that be in a kind of vesicle gel packed with that, or how does that work from a practical point of view?
Yeah, so that would be in a delivery system like a gel, whether it's a hyaluronic acid or some other fibrin type gel. Yeah, either of those. I mean, there's a host of things that we could use to coat and deliver. That's to keep it local, as opposed to being washed away in a arthroscopic setting.
Yeah, and then towards 2040, because that's on this topic. This is the last question that we want to get into, because it's only 16 years away, but in 2040, where do you think we will be with regards to autologous chondrocyte transplantation, or MACI or AC? What do you think the new highlights will be, both in the research perspective and the clinical perspective?
So I think that well, first of all, there'll always be a place in the armamentarium of the orthopedic surgeon to have that available. But what I do see, and I'm excited about, is the increasingly diverse number of different therapies that are currently being developed and are already out there. For instance, CartiHeal, the company, just got last year their product Agili-C approved for not only local cartilage defects, but also for osteoarthritis. So this is the first, FDA approval in the U.S., and I'm sure that has a CE mark. But this is the first one past ACI that has been approved for that. But I see down the line more innovative technologies that can help guide the future of cartilage repair. And one specifically that I think should be further developed. Now, if you think about it, we're taking chondrocytes from all of the specific zones of articular cartilage. So there are 4 zones, from superficial to calcified. So when we put in a cartilage ACI implant, and this is something I've thought about since the beginning, is it's basically cells from those different zones are now intermixed together, all in the same implant. So while we can get them to all form cartilage, when we think about the intelligent design, those zones have specific functions. The superficial zone has the secretion of lubricin, proteoglycan 4, for helping lubricate the surface. It also has, according to some of our colleagues, stem cell population. So the middle and deep zones also act differently. They have different, profiles metabolically. So I think with 3D bioprinting and 3D reconstruction of those different zones, I think that should be the future goal of ACI. And again, if one can manufacture those with 3D bioprinting and have it as an allogenic source, then you would have the sine qua non of cartilage repair, because you would have a cartilage construct, an osteochondral construct that behaves like the regular, the native tissue. And with that, I also think that we grossly and you touched on this actually briefly, subchondral cysts and things of that nature. So when we do the surgeries, what are we actually doing with regards to the subchondral bone? Because when we have a cartilage injury, we know that we have altered biomechanics in some ways, and that can lead to subchondral cysts and so forth. So should we also think about how the bone interacts with that graft? So in other words, do we need to tack it down into the bone? Should we have a construct that also includes an osteo or a bony component to it that can be used to anchor the product, the graft, and then allow for better integration into bone? Because the last thing we want to do is perforate the bone, allow blood to come in, and then put a new graft in that place, and then see cysts later on, and then collapse of that graft. All those things can happen in a very short time, if not carefully and carefully placing those grafts in place.
Okay, enough food for thought for the year of 2040, and I think enough to work on. That's what I hear. So that's good.
Yes.
I'm very enthusiastic about it. Got very enthusiastic to embark this ship again. Then towards a bit of your role as the current ICRS president, because what is it like to be the ICRS president? Tell us.
Well, I'll tell you this. First of all, it's a very distinct honor. I mean, I'm so proud to represent our organization. I mean, it gives me great pleasure, and to see, and what's interesting, and I'll bring this back to the beginning. I remember when we went to the ORS with Lars and I to present this work, he said, you know what? Wouldn't it be great if we could get all the people in the world that are interested in cartilage repair together and have a meeting? And I looked at him and I said, Lars, there's like 4 people in the world at this time that are interested in this. So I don't see that as, I think it's a great idea, but can that be possible? And now, when I look out at the audience at the ICRS World Congress, and I see how many people from industry, from the clinic, from basic scientists, all singularly focused on cartilage repair, and the fact that I helped, spawn this whole basic concept, this field of research, it gives me a great honor. And I think as far as like some of the challenges I have, one of the things I want to do certainly is increase membership. That's definitely something we need to do. There's a lot of emphasis now on DEI, diversity, equity, and inclusion. I want more. I want more basic scientists in the field. That we have a significant number, but I think they're the engines that drive new technologies and help. The whole society is focused on basic to clinical translation. So they have scientists and clinicians together. We're going to solve those problems. I also want to cultivate the younger scientists, the next gens, to be involved with. For instance, we're going to have a strategic planning meeting, and we have. I think we want to invite some young people just to sit and be involved to see what the society is trying to do for the strategic future of the society. So I think these are some of the future goals. I also want to use real world evidence that we have to support some of the orthobiologics, because as you know, we have now a host of new things like platelet-rich plasma, bone marrow aspirate concentrate, BMAC, and lipoaspirate that are now being used for OA and other research, in cartilage repair. So using that to help inform, to provide evidence-based medicine for approval of these things, I think we can be very strategic in that regard. And then partnership with other organizations, I think, is key. Like we have a good relationship with ORSI. I'm looking to also bring in some of the and the BA, the Biologic Association. So I'm also looking to bring in things like the PMNR folks and more radiologists, because they also have a stake in this game. because that, how we see cartilage imaging is important, right? And then I think, certainly building consensus with our partners is important, and also, to preserve, if I can, the intellectual body of, the minds of our wonderful members, because, as you know, there's a lot of us have other societies we're involved with, and so we have a brain trust of people in our society that, I want to maintain that in a way that we can leverage it for other purposes. But you know what I'm saying, as far as I don't want to give away all the stuff that we have. I think we have a lot, and in the society, as far as our intellect, our goals, and I don't want to dilute it. So I'm looking for ways to, partner with other societies, but not, dilute us in ultimately. So that, that's one of the goals I would also look to.
Well, that's good to hear, and I think you touched already upon the collaborations that you wish to strengthen, and also put in some new collaborations. As I'm also an ICRS member, but also part of the ON team, and this podcast is of course supported by ON and made by ON. But how do you see the collaboration between, for example, this the ON Foundation and the ICRS, and where do you think this will be headed in the future?
Well, I think that first of all, I'm delighted, and I'm very happy to work with the ON Foundation. I think our work together, supporting fellows and that kind of and grants are certainly something that we look forward to working with you on. Whatever we can do to enhance you is going to be mutually amenable to both parties. So I think it's a strong and long relationship that I would like to certainly do whatever I can on my end to ensure that the ON Foundation has a stake in our society. Certainly.
That's good to hear. I can only agree more, I guess. So I think that's it for the topic on the ICRS. I think we heard great things, and of course we're looking forward to the next conferences that we'll go to for the ICRS. Already looking forward to Boston. And then just to close off the podcast, we started with the warm up, but we also come back with the cool down, and that's some more personal questions. But I would like to ask you if you would be able to have a cup of coffee or a cup of tea with one person in the world, either dead or alive, who would it be and why?
Okay, that's a great question. And certainly there are a lot of folks I would love to have a cup of coffee with. But right now, I would have to say this. I would like to have a cup of coffee with Neil deGrasse Tyson. He's if you know, is an astrophysicist. And one of my dilemmas in life is, or as a scientist is, so according to the physicists, there's an ever expanding universe from the Big Bang, correct? So what exactly is the universe? If it's expanding, what is it expanding into? Because there's got to be something at the end. So I want a physicist that knows this, that can somehow simplify the physics involved with the expanding universe, and then certainly also to touch upon things like the recent findings from the Webb telescope are just so fascinating. And it's an area that I have, only peripherally looked into, but it's one that I think, questions of the universe are something I'm interested in, certainly. So where we stand and so forth. So that would be somebody I would like to talk to.
Well, that's great to hear. And just a last question, for us as young members of the ICRS or the whole community, part of the orthoregeneration world, what would be one tip or one advice that you would give us?
I would say, having gone through this at this point in my career, I would say, when we looked at the concept of cartilage repair as an example, there were 200 plus years of it doesn't heal, don't bother. But what we showed is that there's nothing that cannot be accomplished without hard work and stick-to-itiveness. So there's always a way to find. You can always find a way to accomplish something. So don't let things, say, oh, we can't do that, it's impossible. Anything's possible. So I would say, don't be discouraged. Always try to. There's always a silver lining to even experiments that fail. There's, you can always have that eureka moment. So don't give up. Keep plugging away. We still have a lot to do, and I wish them all the best for the future.
Well, that's the great end to the podcast. I think on behalf of all the listeners and on behalf of the On Foundation, we are really happy and glad to have you on the podcast. And thank you for all your wise words. And I guess that's it.
All right. Well, thank you. Thanks for the opportunity, and I wish you all the best. And it was a pleasure doing this podcast with you as well. So thank you.
Great.
Inspired by astrophysics, and expand also your knowledge to help advance orthoregeneration by staying tuned for more content at my.on-foundation.org. Thanks for listening and have a great day.